Welcome to Health and Wellbeing Live, sharing knowledge and experience from Nottingham City. We are keeping people informed about issues, people, services that support health and wellbeing in the great city of Nottingham. Welcome to this relaxed podcast style production pitched at an interested and informed audience. You might be staff who work within Nottingham City, you might be staff elsewhere looking for good ideas and to share what we are doing in the city with yourselves and your team. There'll be little dumbing down. These are in-depth, often quite technical conversations, but obviously members of the public absolutely welcome to watch and learn about what is happening. So today we're talking with Bobby Lowen, who is Programme Director for Changing Futures Nottingham City. And for people's interest, I'm Dr. Andy Foster. I'm a GP. I'm one of the directors at NCGPA, and I work at PCN level and place level in inequalities. So welcome, Bobby.
Thank you, Andy. No, it's really good to be here.
Good. And do you want to briefly introduce yourself?
Sure. Yeah. So I'm Bobby Lowen. I'm the Programme Director for Changing Futures in Nottingham City. And Changing Futures is the city-based partnership programme that's working to improve the lives of people who experience severe and multiple disadvantage.
Great. And I guess a large part of what we're talking about today is SMD, or significant multiple disadvantage, which a few months or a year or so ago was quite a new concept to me, actually. So I think there'll be a lot of people out there who maybe don't fully understand what SMD is. Do you want to talk us through what is SMD and also why should we be interested in it as a concept? Why does it matter?
No, good question. And I think it has been a bit of a challenge, actually, that it's a relatively new term and people don't always understand what it means. And actually the definition is always evolving as well. So the current definition, accepted definition, is co-occurring experiences of 3 of the 5 of homelessness, problematic substance and or alcohol use, interaction with the criminal justice system, so either offending or a victim of offending, mental ill health, and experiences of domestic and sexual violence or abuse. So that's kind of what SMD is in the formal definition. Actually, we're always learning around this, so it presents differently for different people, and we're also realizing that it links into other issues that are still not that well understood. So things like neurodiversity, gender, ethnicity.
Yeah, I was going to say from general practice, because we don't know about people's interactions with the criminal justice system, it's deliberately not information held by us. For us in general practice, it's 2 of those 5 characteristics as well. So just for the general practice audience out there, just sort of pointing.
Definitions do vary. Yes, yeah.
Yeah, and that's one of the problems, I guess. Why does it matter to identify or define people as being part of this group, Bobby?
I mean, it's incredibly important. And so if we look at it from a kind of a health point of view, people experiencing SMD face far, far worse health and well-being than the general population, including significantly premature death. And they are also, I guess, there's a whole range of experiences that they have in their kind of the course of their lives, and sort of challenges that create kind of additional risk to poor health and well-being, whether that's about being without a home, whether that's dealing with addiction, those sorts of things, but also kind of difficulty accessing support. So there are lots of reasons that people experiencing SMD can be excluded from support, either through direct exclusions because of trauma-related behaviour, or things like fear and mistrust of services, or just the challenge of when you've got so much going on in your life, and because you've got kind of incapacitated by some of the difficulties, actually kind of being able to link in with particularly preventive support. So what we often see is that people get sick, often with preventable illnesses, and disproportionately use reactive, higher intensity health services, things like A&E, things like unplanned inpatient admissions, so going to hospital or inpatients to mental health wards, and over a longer period of time. So actually, people live unfortunately very, very miserable existences, but also there's a real kind of a cost aspect to this as well. So we know that budgets across public services are pretty tight at the moment. Actually, we're not using the resources that we do have in a particularly efficient way, because we're not kind of getting to the root cause of the difficulties that people have in their lives.
Yeah, and Yeah, you make some really good points there, Bobby. And I guess something that really struck me was reading, I think it was an Opportunities Nottingham report. So I think
Yep,
that's something that was happening before Changing Futures.
it
And they
was.
followed a cohort of people who met the SMD definition. And I think they were quite a difficult and challenging cohort, but it followed them for a number of years. And several of them died during the course of the study. And the average age of death was 47 amongst that cohort. I'm sure you're
Yeah.
familiar with that, but I found that just sort of shocking.
I am, and actually that holds true as well. So that's a figure so that's local. So Opportunity Nottingham was the precursor program to Changing Futures, but actually there are a number of other areas where they've started work around severe and multiple disadvantage, and they see a very similar pattern. And that should shock us really. That kind of level of health inequality is shocking. And I think if we want to have a health system locally that addresses health inequalities and improves the health of the full population, we need to look at multiple disadvantage.
Yeah, no, absolutely. And also, as you're saying, I think it's a useful tool or definition to draw attention to the various components of it,
Yeah.
and also something that can be used to make that funding argument. Both upwards to ICBs and the government, and also that attention argument downwards as well. That the general practice and individual practitioners should know about this, and it's a way of identifying people that do have much higher levels of needs, that maybe need more attention focusing upon them. And I'm just thinking about general practice and the SMD lens. Maybe these people need longer appointments. Just taking it right down to general practice, or prioritize access. To stop them falling foul of the consequences that we know they can. The other side of this as well, which I think is really interesting, is that this is a group that disproportionately has that impact on services as well. So identifying them as a cohort and doing something about it, we can perhaps save money and resources, by approaching this in the wrong way. What do you think about that, Bobby?
No, I mean, you're preaching to the converted on that, and I think that's what I spend a lot of my time trying to get across, because that term SMD is not universally understood, and it doesn't always connect with the different big statutory partners' individual areas of interest, whether that's around homelessness, whether it's about reducing repeat offending, whether it's about addressing mental health or physical health. That's one of the difficulties, I think, in SMD as a label. But actually, what we find is that that kind of disproportionate use applies right across those different areas. And again, it's because of the underlying issues and challenges that people face. So there's a very clear and real human cost with this. The very stark figures around life expectancy demonstrate that. But actually, from a perspective of financial sustainability within our system, which is so important at the moment when we're all very tight for budgets, it really deserves the attention on that basis as well.
Yeah, absolutely. And I think we'll be talking later on about sort of evidencing impact and what we can do to help. So if people can sort of stick around for that a little bit later. I was going to ask, is this even the right term? Because I've spoken to people who meet the SMD category, and often they don't like that label. They perhaps prefer older terms that were things sort of people with complex needs or terms in the past. And I don't know what you think about that. I guess it's a term and it has utility within the system, but in terms of labeling people, what do you think?
I think familiarity with the term is a challenge. I mean, I think it's a slightly more, I think SMD is quite a broad definition, but I think it serves a better purpose rather than kind of proxy. So things that people might recognize, like homelessness, for example, that isn't quite the same thing as SMD. There can be people who aren't currently homeless, who have lots and lots of challenges, which would qualify as SMD and put them at risk of future homelessness. Equally, there can be people who, homeless families who are homeless for different reasons. So in a way, it's kind of more exact, so it's quite useful. But I think the fact that there isn't that familiarity with the term is a difficulty for us. What we're starting to see actually is that SMD concepts are getting through to national and local strategies. So people might have seen the new framework for inclusion health that NHS England launched in November last year. That really, if you look at the groups of people affected, if you look at the kind of issues and challenges they face accessing services, if you look at the financial case for doing things in a different way, that really overlaps clearly with multiple disadvantage. And if you look at things like from harm to hope, the national drug strategy, if you look at homelessness strategy and rough sleeping strategies, again, you'll have those kind of similar concepts there. I think a big part of what we're doing is to try and drag together separate interests for those different organisations that are organised, funded by government to do slightly different things, but actually with the same group of people. So I think it is a helpful term in a sense, because it's more accurate, but actually that level of understanding is still something that needs to be worked on locally and nationally.
No, absolutely. I think from the perspective of sort of driving policy and resource allocation, I think it's a really interesting concept, to pull all of that together, and I think it is having some success. Bobby, I want to ask you about Changing Futures. So I guess let's just ask the question, what is Changing Futures?
Again, there probably are multiple answers to this. So let's start with the easiest one. So Changing Futures is a national cross-departmental government programme, which is about improving how local systems, so again, kind of the NHS, local authorities, criminal justice partners, work together to improve the lives of people who are experiencing severe multiple disadvantage. It was originally set up with a 2-year funding period. That's been extended to sort of 3 years, but the third year, so coming into next financial year, will receive slightly less funding than we've had in those previous years. And a big part of that programme is about kind of learning to inform national policy as well in central government. So Nottingham is one of 15 areas that's received funding through that programme. And that funding is being used in Changing Futures in Nottingham for some direct support for people who are experiencing SMD. So we call them navigators. They have been called personal development coordinators, but really they're allies to help work with people to have more time working around the different challenges that they might have and where they'd like to get to. But it also pays for partnership infrastructure as well. So things like kind of learning about what works, facilitating collaborative working, that kind of stuff. So that's kind of the second, what is Changing Futures? And I think the third one is it's a partnership. So, we're not a standalone separate service. That's not how this works. It is about recognising those interests across the different partner organisations working in the city and in the statutory and third sector, and really reshaping how we work together for the reasons we've just discussed, because this is really important, because it can give us better kind of use of our collective resources.
Yeah, that's really helpful. And I guess my as a GP, my main interaction with Changing Futures is, well, I guess twofold really. So as a GP who's become interested in SND, I've found that there is a really fantastic monthly Friday morning partnership meeting with, I think sometimes 40, 50 people from really diverse organisations, from the police, fire and rescue, city council departments, GPs are there, people from secondary care, people from the mental health trust. It's really, really fantastic, and that's been running, I think must be since the pandemic,
over 3 years,
I guess.
Yeah,
and that's actually great, and there's so much great connections being made in information sharing. So I think that's a really good kind of aspect that's visible to me in Changing Futures. And then of course there's a Changing Futures program that we can refer into as GP surgeries as well, and I've referred a few people down that pathway and encouraged colleagues to do the same, and those are my experiences of it. But I guess that, I'm sure there's so much more going on as well. Bobby, what's your role within it? Do you want to just briefly tell us what your role is and how you arrived there? Because I always, when I talk to people on this, I often automatically assume people are doctors or nurses by background, which is my narrow world view, but people have done all sorts of things. What's your story?
No, for my sins, for a very long time, I was a commissioner working in the local authority. And so I suppose what I saw there, so I was involved in commissioning various different services over the time that kind of lean into health in particular, or had some health aspect to them. So I'd commissioned mental health services, for example, and different types of support and adult social care, homelessness services for rough sleepers, a range substance use treatment. So a range of different things that kind of fit with severe multiple disadvantage. And I always found it quite frustrating, actually, that it was really quite difficult to join up our efforts. And there was always, I think, a kind of a thing of trying to work out where the responsibilities start and end for each of the organisations and services. And I suppose, a lack of kind of collective ownership for somebody's outcome. And I think that leads into the kind of the inefficiency and the poor results that we get for people. Not necessarily the fault of people working in Nottingham. I think it's just an issue with the way that government funding is administered and the responsibilities are separated. So during the pandemic, I was involved in a piece of work, government programme called Everyone In, which was about a very urgent response to people who were at risk of sleeping rough. And there was a lot of fear at that time that those people would be particularly vulnerable because of underlying health risks. Now, it shouldn't take a pandemic, but actually the pandemic gave a really good excuse for us to say, well, let's not look at the different contracts and separation of responsibilities. Let's come together and work out what we need to do for this group of people who actually were all people really experiencing multiple disadvantage. And it worked incredibly well. And we found that we could do things that we weren't doing before through that collaboration. So we agreed, and that's the beginning of the SMD partnership meeting, that meeting that you mentioned, to continue after the pandemic. And we also put in an application to the National Fund, the Nottingham City Place-based. And so that's kind of where Changing Futures came from. That's my kind of route into it. And so, yes, now I feel like I'm kind of in a place where I can affect a bit more of that sort of system change and encourage collaboration that I couldn't do before.
I think that's brought us up to speed with your role. Yeah, so, and you're the program director. So what are you doing day to day? Not to spend too long answering that question.
No, yes, sorry, I missed that part. So I suppose there's two parts really. So one of them is about that kind of taking that message out to the different partner organisations and saying, this is something that I think is going to be useful for you to explore and to try and look at how you can kind of improve whatever outcomes you're looking to achieve, whether that's reducing homelessness or improving health. And also to listen to them and understand the kind of the different challenges that they're facing with, and think about how we can be helpful within the programme, and to, in general, kind of build awareness of multiple disadvantage. The other part of it is about overseeing the use of the resource that we've got in our programme. So there are various parts of it. I've mentioned the operational part, the kind of the allies, I suppose, navigators who work one-on-one in a kind of compassionate way to understand people's circumstances and to link in with different partnership support. But we've also got people hosted in different organisations across the system, including in the GP Alliance, but also in the council, in the Mental Health Trust, in probation and other areas. And we have kind of learning function. So this is all quite new. So a lot of what we do is about trying to understand what works for people and then try and take that message back through into the system, including through our shared training learning hub, the practice development unit. And then we've also, lived experience is really fundamental to what we're trying to do through the programme. And it's not something that we look at as an obligation. It's something that really improves the decisions that we're making, because we hear firsthand from people about their experiences and what's worked for them. So there's quite a lot that's kind of, and I think I've just skimmed the surface there within our programme. I guess it's my job to try and bring all that together and kind of push it forward in the same direction, and to try and take the different partners with us.
Yeah, sounds busy and complex,
Can be,
but also rewarding. I guess.
Very rewarding. Yeah.
So you were mentioning sort of beginning to learn what works, and I was just wondering, what sort of things do we know or have we learned works for people experiencing these problems? Because it can seem a bit insurmountable, when you meet these people, with these problems as a GP. You think, oh gosh, I've got 10 minutes. There's the rest of the system out there, but this is so complex. How will we make progress? What works, and what are the key things to focus on?
I think you've just touched on something that is really key there, and the kind of wherever people are in different areas of the system, they are seeing people who have much more than their area. So even the best clinician, with the expertise that they have around health, I guess, that outcome that they might achieve for somebody, improving their health, will that be sustained if they're going back to a situation where they are vulnerable again, where they're homeless again, where they're using substances again, where their mental health isn't attended to? And actually that complexity, when you've got a 10-minute window at a very short interaction, can be too much. And it seems insurmountable. So partnerships are really what matter here. We need a kind of a response for people that really looks at them as a whole person, the different things that they've got going on. And that depends upon yes, kind of you can have allies, but you also need to have that appropriate engagement across the different partners to make sure that people get the right sort of help. The other thing I think is really fundamental is compassion, and I suppose trying to work in a trauma-informed way. That's a bit jargonistic, but I guess for me that means understanding why people demonstrate certain behaviours and trying to take account of it. So if people are missing appointments, for example, if they are agitated in a waiting room, if they are quick to anger, well, what's going on in their lives that might mean that they are presenting like that? And how can we make adjustments to be able to help people, whether that's about more flexible appointment times or being more proactive in trying to reach out and give people support, or having people that can spend more time with them and understand not just what the service is there to do, but actually what they want to talk about and the difficulties that they have.
Yeah, no, absolutely. And
which is often overlooked as well. And I almost did it myself. Yeah.
And I'm just thinking to some of the elements of the SMD, local enhanced service, that we have in general practice that encourages us to do trauma-informed care training and psychologically informed environment training to make sure that the environment is right, that the way we set up and deliver our appointments and the times of the appointments supports this cohort of people, and as you say, the way that we understand and interact with people is informed by knowledge of their past, or just being aware that there may be things that we don't know that are driving certain behaviors that we might first initially perceive as difficult. So I'm wondering, Bobby, what are the particular challenges or priorities in Nottingham? It strikes me that we might be a city that has particular challenges as opposed to other core or other cities. We might also be positioned with particular advantages or opportunities as well. How do you see that landscape for Nottingham?
I think that's true. So yes, the challenges, and if you look at the demography of Nottingham, there is more deprivation in Nottingham. Deprivation tends to line up with experiences of multiple disadvantage. So I think there's that issue within our population, but also I guess in the kind of the funding that we've got from government and a lot of the different partners that we work with at the moment, they have been stretched with demand. They don't necessarily have the resources that they would like to be able to do the best job for people, or to engage with extra programs, I suppose. And I think there's a risk that Changing Futures and SMD could fall into that category. So we've been working very hard to try and show that actually this can be a solution to that problem. I suppose by kind of creating more efficiency in the system, getting better results for people, so that you can kind of turn off that longer term demand for reactive services, healthcare, criminal justice interventions, all of that stuff. And also by kind of reducing duplication. You've got lots of people who are kind of working with the same person. So how can we kind of make them come together in a kind of more efficient way to help with people? For strengths there, so there are challenges without question. I think Nottingham's led the way on this, probably because actually we've got that adversity in the city and it has to be important to us. So if we look in the city health and wellbeing strategy, you've got severe and multiple disadvantage there as one of 4 overarching priorities, alongside much better understood, more established health and wellbeing, public health factors like smoking, like kind of keeping a healthy weight. So it's already really getting that focus. And we have, I think, a really kind of diverse, robust, resilient, innovative arrangement of services that and people who work for those services who really kind of want to come together and make a difference on that. So, I think, yes, we have some, we have the need in the city. There's a lot for us to respond to, but actually we've got a team of people, a very wide team, who are really motivated, who understand this, who want to kind of do something different. I think we're still kind of dealing with, it shouldn't just be about people who are have a kind of a core role around multiple disadvantage. We really need to kind of get that message across right across the different statutory partners, the different voluntary organisations that are out there in the city, so that they can recognise SMD, so they know what works, and so they can kind of link up in our partnership.
Good. So Bobby, moving
Yeah.
forwards, what are your priorities for Changing Futures? Looking forwards to 2024, what's sort of top of your in tray?
Well, so I mentioned that we've been funded through a national government award. That will continue. So we received less funding than we did this year rather, in the coming financial year. But actually, we worked with the ICB in Nottingham, Integrated Care Board, the health commissioners, and they have made a decision to award health inequalities and innovation funding, which will mean that we have a future. We can keep this work going. And so they've been forward thinking in doing that, so to be credited for it. But I think it's also about really recognizing that there's a very clear financial case for them to do that, and also in terms of their responsibilities to improve health and well-being. Now, I would like to kind of build on that. So I think there are still people that we aren't connecting with at the moment who we aren't able to do as much as we'd like to do. And I think it's about us trying to continue that work with organisations that have efforts and resources locally and overlapping shared interests to bring that effort together. So that's kind of a really key one for us. It's about continuing that push with our different partners and making it relevant to them, their objectives, the challenges that they're experiencing. I think beyond that, it's about us being able to continue to refine what we do and make it better. And, so I think keeping up the learning is absolutely essential. We have a really good insight and development hub and links to universities that are really helping to look at the different things that we're doing and understand what could be improved and to start to show the impact. And alongside that, we have an analyst who works in the ICB in what's called the System Analytics and Intelligence Unit, to improve our understanding of the difference that we're making. So, things like those attendances at A&E, things like unplanned inpatient admissions, which from our analysis of case files and all the rest of it are showing are much, much higher for people who are experiencing SMD. What we want to do is to make that much more systematic so we can actually look and see what actual interactions are like. And I think also, widening that kind of interest is really part of it. So that's not just about appealing to service people who are involved in kind of planning, commissioning services. It's also about reaching out to our much wider workforce. So we've got what's called the Practice Development Unit. It's our shared training and learning resource. We want to encourage a much wider section of the workforce to kind of come and have a look at those resources, to learn about SMD, to learn about what they can do in partnership and separately to make a difference for people.
Yeah, and I would say that the practice development units materials are really, really nicely executed, really, really attractive. The artwork is good, just in terms of how it looks. It really does draw you in. So I'd encourage people to check that out. And I think Tim can probably make sure there's a link to that under the video here.
So there's some great resources, and I should say as well that they are free resources. So we're really, really keen. And I don't know if there's a way that we can put a link up. It's www.pdunottingham.org for people who've got fast fingers. If you can have a look there, sign up. All of those resources are free to use. The other thing that I think really is worth mentioning is the lived experience side. Now, we've learned a lot by working in partnership with people with lived experience and collaborating in commissioning, planning, all of that kind of stuff. We'd like to kind of make that something that is more understood. And I guess again, when health commissioners are thinking about, or planners are thinking about their services, that they do something similar. I know that there are pockets of good practice. I think we'd like more of it.
Yeah, I'm also aware, just thinking back to the PDU's PI, psychologically informed environment, and TIC, trauma informed care training, which was developed for public services. My understanding is that Tesco locally have picked up on that training and have delivered it. Is that true, Bobby, or is that something you can?
No, they did. Yes, it is true. Yeah. It's every little helps, as I say. So I think that this is something that really affects a lot of people. We see people who are clearly in difficulty. We often see people who we suspect might be having difficulties with their mental health, or not be housed, or have addictions, and people don't really know what to help. And I think Tesco is one of those places, a very, very big employer, and people often kind of, might be involved in minor offences, shoplifting, those sorts of things, and staff don't know what to do, don't know how to help. So, we went along with Dr. Anna Tickle, who is the clinical psychologist working in Framework, who has expertise around severe multiple disadvantage, and delivered some training to some of their decision makers. And I gather that's being picked up and used in some of the stores around our region as well.
That's a really impactful story, really, to maybe start to wrap up. Thank you very much for spending time talking to us today, Bobby. It's been really, really insightful. Thank you so much. And the final question is, what should people do immediately after they close their YouTube or their podcast app? If you could ask them to do one thing to improve their understanding of this area or take things forwards, what would that be, Bobby?
Well, firstly, really grateful to be invited on to talk about this. As I said, kind of awareness is essential. And actually, this is a way of kind of making more people aware of what I think is really, really important, and the things that we can do. I think, again, I'd probably give a push for the practice development unit. That really has the kind of the resources, some simple introductions to multiple disadvantage that kind of will explain what's going on in a quite an accessible way. And then offer a kind of a route through to kind of more learning. And hopefully, if you go on there, you can also sign up to the newsletter, and that will talk about the range of work and ways to get involved in our program. It really matters. And I hope that people will reflect on kind of their own experiences and think, oh, actually, I wasn't too sure what to do there, or I spent a lot of time working with this person. I wish there was something else that I could connect it to for support. That's what we're trying to do. So please do take a look.
Fantastic. So quick place to end. Thanks again, Bobby. Thanks everyone out there who's spent their time listening or watching this podcast. Thank you very much. And hopefully you'll see us soon. Bye-bye.
Thank you.